Hello, lecture number 9, and it will be about causative agent of sexually transmitted disease. Sexually transmitted diseases, diseases which are transmitted by direct contact, actually person-to-person sexual contact. And there are a lot of different causative agents, viruses, bacteria, and fungi, and parasites. And main bacterial sexually transmitted disease is caused by Neisseria gonorrhea. They cause gonorrhea, chlamydia trachomatis. They cause urethritis, cervicitis, ureaplasma ureolyticum, Mycoplasma genitalium, Gardnerella vaginalis, Treponema pallidum, and Haemophilus ducreyi. Today we will speak about gonorrhea, syphilis, and chlamydiosis. Okay, if we will talk about viral sexually transmitted disease, you should know human papillomavirus, HIV infection, herpes infection, hepatitis infection, and cytomegalovirus. Through the protozoan sexual transmitted disease, the most is trichomoniasis, which cause trichomonas by Trichomonas vaginalis. Okay, let's start with syphilis. The history of discovery, it began in 1905 when Chaudin and Hoffman discovered Treponema pallidum as a causative agent of syphilis and revealed spirochetes in the fluid smears from secondary syphilis lesions. And also Wasserman, Ehrlich, Mahoney, they give they give their contribution in researching of syphilis and what you know nowadays. Causative agent of syphilis is belong to the family Spirochetaceae and genus Treponema. Pathogenic species is Treponema pallidum. And Treponema pallidum has 3 subspecies and 1 closely related species. And subspecies pallidum, which cause venereal syphilis, Treponema pallidum species endemicum, that cause endemic syphilis, or Beigel, Treponema pallidum subspecies pertenius, that produce yavs, and Treponema caratheum, the agent of Pinta. Morphology. It's a gram-negative, thin, curl-shaped bacteria, and it has 6 to 20 regular small coils with tapered ends. The cytoplasmic membrane lends Treponema a spiral shape. It is like of producing spore or capsule. All Treponema culture form cyst-like structures. In the morphology of Treponema, there is one special features. It is not like another bacteria because Treponema and all spirochetas they have turret shape, and also their flagella is inside the cell wall. Microbial body consists of an axial filament and cytoplasm bound spirally around the filament. Cytoplasmic membrane is covered by 3-layer outer membrane. It covers basal bodies with attached 3 or 4 bacterial endoflagella or fibrils localized in periplasm space. Endoflagella provide active variable motility of bacteria. So its flagella is inside the cell. It is between cell wall and cytoplasmic membrane. Cytoplasmic membrane is thin and cell wall is gram-negative. And this flagella is known as axial filament, and it composed of protein flagellin, and it can move. So the motility of high motility of spirochetes is because of this specific filament. So in this picture, you also can see the filament or flagella, which are connected with specific blepharoplast. The place where flagella is connected with cytoplasmic membrane is known as blepharoplast. So the place of connecting of filament is named blepharoplast. Filament, it's like flagella. Okay. The name Treponema pallidum is because of lack of because Treponema does not colorized very well, so it does not colorized by gram stain, and it stay pale with all usually applied staining, and that's why its name is Treponema pallidum. The bacteria stain pale pink with Romanowsky gypsum method as they poorly stained with aniline dyes due to the large lipid contents. Treponema can be detected by silver impregnation method, dark field, and phase contrast microscopy. So dark field is the best method of microscopy for this bacteria. Cultivation. They are extremely fastidious, so they can be grown on the nutrient media, and for cultivation usually organism of rabbit can be used. The Treponema pallidum grows well on the maintained virus by animal inoculation in rabbit testicular tissue treponemas. Rabbit infectivity tests require from 3 to 6 months for cultivation, and so that's why bacteriological and cultural method is not good for diagnosis, just for science reasons. Biochemical properties, they have slow metabolites, unable to synthesize necessary growth factors. That's why they can be cultivated in artificial media. Treponema pallidum does not produce superoxide dismutase, catalyze, or peroxidase. Antigenic structure. So there are 3 core proteins of endoflagella and they are similar with other bacterial flagellin proteins. Lipid antigen include phospholipids, cardiolipins that shows mimicry with bovine heart lipid antigens. It is important for syphilis serological diagnosis. So you should notice this that lipid antigen of trypanemia is very similar to lipid of the eukaryotic cell, especially to cell of bovine heart. Multiply lipid and protein antigens of Treponema pallidum cause hypersensitivity reaction of host immune system. Virulence factor. Treponema pallidum bears membrane proteins that may function as porins and adhesins. Not shown to produce LPS endotoxin or clear exotoxin, but can develop cytotoxin activity against various cell culture. Hemolytic activity also may produce hyaluronidase, which promotes microbial invasions. Pathogenesis of syphilis is closely associated with host autoimmune reaction triggered by a microbial agent. And also high invasive ability because of motility play important role in pathogenesis of syphilis. Treponema pallidum, they can invade to the cell, especially to the endothelial cell, and damage endothelium of the vessels. And this is one of the main moment in the pathogenesis, and also autoimmune reaction. Resistant. They are very sensitive to drying, heat, and action of chemical disinfectants. Heating at 55 degrees kills Treponema pallidum in 50 minutes, but stay viable for a mindful time in tissue, especially at low temperature. Survive for 1 day and even more in blood or plasma stored at 4 degrees. Treponema pallidum penetrates through small lesion in the skin or mucosal. Infection dose for disease is minimal. As little as 1 or 5 microbial cell can cause the disease. It's very important because usually we talk about 100 of microbial cells to cause the disease. And in this case, it is enough only 1 microbial cell to cause the disease. Incubation period depends on inoculated dose. There are several consequent stages in syphilis course. After 7 or 19 days of incubation, this average about 3 weeks, a heart chancre, essentially tissue lesion or primary syphilis, appears. So, primary syphilis, it's a chancre. It's a chancre in the route of infection. It is followed by regional lymphadenopathy. Chancre involves at the primary site of microbial entry. Heart chancre is painless ulcer, about 0.53 centimeters with sharp margins, clean base, induration, and sometimes with purulent discharge. In most cases, chancre heals spontaneously within about 6 weeks. Heart chancre is painless ulcer, and it contains a lot of treponema, and it plays in the microbial entry, in the site of microbial entry, and also heart chancre is the result of necrosis and vasculitis in the place of in the route of infection. Treponema enter to the route of infection, cause necrosis and cause vasculitis, and that's why heart chancre occur. In most cases, chancre heals spontaneously within about 6 weeks. So after 4 or 5 or 6 weeks in the place of entering, there is nothing. In several weeks, the disease comes into the next stage, secondary syphilis. So the heart chancre, it's a primary syphilis. And next, primary syphilis is continue about 4 or 6 weeks. Second stage, it's a secondary syphilis, which result from lymphogenous and hematogenous microbial dissemination. Secondary syphilis, it's a stage with dissemination to the bloodstream. Secondary syphilis is characterized by skin rashes. Skin rashes is because of damaging of the skin vessels. Headache, fever, malaise, lymphadenopathy, mucosal lesions, and sinus disorders, and it lasts from 2-3 months to more than 1 or even 2 years. Primary and secondary syphilis lesions contain great amount of spirochetes, being highly infectious, especially secondary syphilis, because in the case of primary syphilis, treponema contains only in the place of infection, only in the heart chancre. But in the case of secondary syphilis, treponema contains in all bodies fluid. All bodies fluid contain treponema, because treponema goes to the blood and generate and disseminate to the all organs and tissues. It is important. In secondary stage, specific immune reaction against spirochetes arise, seropositive syphilis. Primary syphilis is seronegative. All serological reaction will be negative. And in the second stage, serological reaction will be positive. Hypersensitivity response does not provide completely microbial elimination without antimicrobial treatment. And after latent period of various duration, about 1 year and more, the tertiary syphilis develops. Nowadays, we don't have a lot of tertiary syphilis, only in the case without treatment. But when syphilis was treated with uh, some uh, some drugs like herbal drugs, like oils, but not antibiotics, it was a lot of tertiary syphilis, and tertiary syphilis brings a lot of damage to the organism, and people who have a tertiary syphilis, they are invalids, because tertiary syphilis, it's a systemic disease with damaging all tissue and all organs. Tertiary syphilis affects various body organs and tissue, especially cardiovascular system and CNS. Syphilitic aortitis damage the ascending aorta. It may happen between 10 and 30 years after primary infection. Specific slow indurative injuries, glumas, emerge in central nervous system and parenchymatous organs. They are followed by necrosis and connective tissue proliferation. The last period of disease is characterized by profound CNS disorders, neurosyphilis. This period is usually regarded as seronegative because spirochetes are absent in bloodstream and antibody titers are low. So in the tertiary syphilis and neurosyphilis, treponema presence in the gummas, and gummas is a result of hypersensitivity, delayed hypersensitivity, and gumma it's like granuloma in tuberculosis. It's very similar. It's a cell reaction, cell immune pathological reactions, cell allergic reaction, hypersensitive delayed hypersensitivity. So look at this picture. Treponema pallidum can be transmitted by direct contact, direct sexual contact or contact or live contact. For example, to to eat from one spoon or to drink from one glass and something like that. And children, they can catch syphilis by this way. Okay, and Trypanosoma pallidum entered to the organism by through the damaging skin or mucose, and primary syphilis occur. Incubation period can be very long, 10 to 90 days. And primary syphilis is characterized by painless ulcer, heart chancre, and it continues through 3 to 6 weeks. And after that, at the end of primary syphilis, the ulcer is absent and trypanemia goes to the bloodstream and secondary syphilis began. Secondary syphilis, it's a spreading, it's a dissemination through the all tissue and all organs. That's why secondary syphilis is the most contagious period of syphilis. And one of manifestation of this stage is a skin rash because of damaging of skin vessels. And patient can have fever, malaise, sore throat, and abnormal seeds. Then usually latent syphilis and occurs. And latent syphilis, it's like remission. And it's a part of secondary syphilis with the manifestation and the bacteremia, then latent syphilis with no symptoms when bacteria are in the organs. And the last stage is tertiary syphilis, formation of delayed hypersensitivity, formation wounds in the CNS, in the inner organs and tissues, involvement CNS, and tertiary syphilis is not so contagious as secondary or primary, but it is a systemic disease, and it brings a lot of damage in the organism. Okay, here you can see the stages, timing, and features of each stage. The immunity in syphilis is not sterile. It always causes patients hypersensitivity. Immune response usually doesn't prevent disease progression, but autoimmune reaction accelerate tissue damage and aggravating the disease course. Not sterile means that this immunity is only in that period when bacteria are in organism, but after elimination of bacteria, all immune reaction stopped. Laboratory diagnosis rests on microscopical examination of lesion specimen for trypanosomes and or serological test for specific antibody. Microscopy is the main diagnostic method for primary syphilis. It also may be used in secondary syphilis. Specimens are collected from chancre discharge, rash elements, lymph node aspirates, Romanowski James stain, silver impregnation, and actually dark field microscopy can be applied for testing for Trypanosoma pallidum. Serological testing. Laboratory diagnosis for latent, secondary, and tertiary syphilis, but not primary. In primary syphilis, all serological tests are negative. That's why they can be applied in this period. The method of analysis include non-trypanemal and trypanemal reaction. Non-trypanemal reaction are implied for mass screening, whereas trypanemal tests are confirmatory. So we have a lot of we have tests for mass screening. Mass screening means that a lot of people are testing with this test, and if somebody gives positive reaction, they must be administered the treponemal test for confirming. By non-treponemal test, we can't confirm syphilis. Only choose the people who must be tested with the treponemal test. Non-treponemal test have two similar reaction: venereal disease research laboratory test, viral test, and rapid plasma reagent test. Both tests are based on flocculation reaction. In this method, a complex antigen containing lecithin, cholesterol, and purified cardiolipin is used to reveal host antibodies against cardiolipin that arise in syphilis. The method is cheap and rapid, but of limited sensitivity, and it can give false positive data in autoimmune disease patients with malignancies, tuberculosis, leprosy, viral parasitic infections, and pregnancy, because they reveal antibody against cardiolipin. And when I told you about treponema antigen, I said that treponema's lipid antigen is very similar to lipid of eukaryotic cell. And that means if in the organism occurs process with cell destroying, like in the case of autoimmune disease, tuberculosis, malignancies, and other. Also, it this organism can have antibodies against lipid antigen. They called reagents, antibodies reagents, which appears in the process of cell damaging, cell destroying, and also pregnancy. And that's why non-treponemal tests can't confirm the syphilis. It's very important rule. If treponemal test, VDRL test, or rapid plasma reagent test shows positive reaction, it does not mean that this patient has syphilis. It means that you should administer to this patient treponemal test. It means that this patient needs deep diagnostic method. And treponemal tests comprise serum fluorescent treponemal antibody absorption test, as well as T-pallidum immobilization test, microhemagglutination test, and ELISA for detection antibody against treponemal pallidum. In treponemal test, proteins antigens from treponema pallidum is applied as a diagnostic. So they show the presence specific anti-treponemas antibodies, and they confirm syphilis. These tests use pathogenic killed or live treponema pallidum cultures of the filtrate of viral tissue treponemas as an antigenic source. ELISA test is regarded as the most convenient and universal for routine laboratory diagnosis of syphilis. Okay, PCR also can be applied in syphilis, and actually we usually use PCR, not microscopic method nowadays for diagnosis syphilis. And it is swift, sensitive, reproducible method. It becomes available now in wide clinical practice. Here you can see RPR test for diagnosis syphilis, and it can be performed on this paper. This paper consists of specific cardiolipid antigen, and you should take serum from the patient and put the serum for this paper to this paper. And if you don't see any agglutination, if you don't see any conglomerates, it means this reaction is negative. And if you see some conglomeration, it may be weakly reactive or strongly reactive. And this reaction is this means that you should take this take this patient and apply a specific treponemal test. Screening algorithm traditional. Okay. First of all, we use, of course, non-treponemic test. It's a screening reaction, means a lot of people every day are tested with this test. When you go to the therapist, for example, where you go to the clinic and where you go to the work, maybe they require the test or the results of test to the syphilis, result of non-treponemic test. So a lot of people are tested with this test just for screening, just to find people with positive reaction. If reaction is negative, that means that it's that this patient doesn't have syphilis, or maybe also it's a early primary syphilis. You should notice that early primary syphilis is seronegative. But in the case of early primary syphilis, that must be manifestation with heart chancre. If non-treponemic test showed positive reaction, it is proposed to do treponemic test. The best is ELISA. And if treponemic test is negative, that means that it's not syphilis, just false positive. It was false positive reaction. And if it is positive, it means that this patient has a syphilis. Confirmation of diagnosis. Clinical diagnosis of primary syphilis is confirmed by positive result of microscopy or positive result of non-treponemal and one treponemal test. Secondary syphilis is diagnosed by positive data from one non-treponemal or one treponemal test. Tertiary syphilis should be confirmed by 2 or more treponemal tests. Treatment and prophylaxis. Okay, also I need to add that primary and secondary syphilis can be also confirmed with positive PCR reaction. Treatment and prophylaxis. As treponema pallidum has no genetic resistance to beta-lactam drugs, benzene its a long-acting derivative, benzathine penicillin, remains the drugs of choice of syphilis treatment. Tetracyclines and macrolides can be used in case of patients allergic to beta-lactam antibiotics. Prophylaxis of syphilis is non-specific. It requires public education, screening for syphilis, timely recognition of syphilitic case, their adequate treatment, and improvement of socioeconomic condition. Nowadays, we have a lot of cases of syphilis, but we don't have tertiary syphilis, and this is a good news. And we don't have tertiary syphilis because of timely recognition of syphilitic case. Okay, next is gonorrhea. Gonorrhea is more spreaded than syphilis. Gonococci were described by Neisser in 1978, And later, Baum obtained the pure culture of this bacteria. It belongs to the order Gracilicutes and family Neissereaceae, genus Neisseria. Genus Neisseria consists of two species, two main pathogenic species, Neisseria gonorrhea and Neisseria meningitis. Neisseria meningitis is a causative agent of meningococcal infection, and Neisseria gonorrhea is a causative agent of gonorrhea. Like Neisseria meningitis, Neisseria gonorrhea also gram-negative bean-shaped diplococci. Non-sporoform, non-motile, express multiplied pili and fimbriae. So look at this picture. You can see pili and fimbriae, and they play important role in the pathogenesis of gonorrhea. Neisseria gonorrhea most fastidious than meningococci and can't multiply on basic nutrient media. They are cultivated on media containing blood, serum, or acidic fluid, better in atmosphere with 5 to 10 process uh, uh, um, better in atmosphere with 5 or 10 carbon dioxide and pH 7.2, 7.6. Optimal growth temperature is 37. The bacteria allows viability out of range 25, 32. So they are mesophiles. Very small convex colonies, opaque or transparent. Uh, because of fastidious, the cultivation is not applied for diagnosis gonorrhea. Biochemical properties are aerobic or facultative anaerobic bacteria, minimal biochemical activity, ferment soluble glucose with acid and products being lack of proteolytic activity, produce oxidase and catalase. So here you can see uh, how do they grow on the blood media, and uh, they grow with transparent, not big colonies. Antigenic structure. Various antigenic determinants or polysaccharide and proteins nature. Bacterial pili contains protein pilin, which significantly varies among gonococcal strains. Gonococci express a number of porins, namely pore A, pore B proteins. Adhesive opacity proteins also render antigenic activity. Polysaccharide epitopes of gonococci are confirmed within bacterial cell wall lipopolysaccharide. Okay. The antigen of uh, pili, antigen of uh, lipopolysaccharide, some adhesive proteins, and some porin proteins. Virulence factor. All that factors, all this antigen are virulence factor. Bacterial adhesions. So let's return to this picture. Look at this picture. You can see a lot of fimbria and pili, and that means they can very strongly, very closely adhere to the eukaryotic cell. And also they have proteins which cause intracellular invasion. And intercellular invasion usually occurs in the phagocytic cells. They can invade to the phagocytic cell and prevent phagocytosis. They can multiply inside the phagocytic cell. Also, microbial lipopolysaccharide displays evident in the toxin activity, but not like in the toxic activity like enterobacteria do, or Neisseria meningitis do. They this and the toxin only cause inflammation by stimulation of cytokines. Also, it can destroy mucosal immunoglobulin A by immunoglobulin A protease enzyme. Many bacterial strains express plasmin called beta-lactamases, and that's why they can block beta-lactam antibiotics. Resistant, they have low viability, being very sensitive to external influence. They can't resist cooling, drying, or ultraviolet irradiation. Best to survive in the most moist condition in various human discharges. Bacteria are killed at temperature of 36 within 5 minutes. They are readily inactivated by treatment with ordinary disinfectants. Pathogenesis. Gonococcus is a strictly human pathogen. Gonorrhea is a typical sexually transmitted disease that affects predominantly urogenital tract. Also, gonococcus produce gonorrheal conjunctivitis in adults and ophthalmia neonatorum or blenorrhea in newborn infants transmitted by contact through. If a pregnant woman was ill with gonorrhea. Her newborn can catch gonorrhea uh, through the process of its his birth. In the process of birth, newborn can catch gonorrhea from his mothers with gonorrhea. Gonococcus attach to mucus and induce acute inflammation. They stay viable within phagocytes, impairing their bactericidal activity, incomplete phagocytosis. When untreated, the disease produces chronic inflammation with extensive tissue fibrosis and seminal duct obliteration. They may cause male infertility. This leads to hematogenous microbial spread with hemorrhagic skin rashes. Gonococcal dissemination may produce specific arthritis or endocarditis. It is not usual situation when gonococcal can disseminate to the bloodstream, but in the case of chronic gonorrhea, it can be, and it was proved that Neisseria gonorrhoeae can cause endocarditis in the case of chronic gonorrhea. So on this slide, you can see the pathogenesis of gonorrhea. So first of all, bacteria adhere to the urogenital epithelium. For this process, it has a very strong fimbriae and pili, and by this pili, it adhere very strongly to the urogenital epithelium. And competition with resident microbiota, nutrient acquisition, and microcolony formation, colonization, and invasion. Next step is invasion. So gonorrhea use their specific OPA proteins, porins, and by this mm, by this proteins, it can invite to the cell, destroy cell and invite to the cell, and then it contact with the macrophage. So see at this picture, they use specific proteins which help bacteria enter to the macrophage, and macrophage can destroy gonococcus can make a phagocytosis incomplete. Phagocytosis occurs, and phagocytes start to produce cytokines, and cytokines it's factors of inflammation. Diagnosis of gonorrhea. Specimens are collected from the discharge of urethra, vagina, vulva, cervix, rectum, or conjunctiva in case of ophthalmia neonatarum. Gram-stained smears of secretion show typically gram-negative, pin-shaped cocci within polymorphonuclear leukocytes, incomplete phagocytosis, or extracellular. But microscopic method can be applied only in the case of acute gonorrhea, but not in the case of chronic gonorrhea, because in discharge of patients with chronic gonorrhea, there is not a lot of bacteria, but in discharge of patient with acute gonorrhea, we can see a lot of bacteria and in the smear and a lot of leukocytes. More sensitive and specific is the immune fluorescence test, but it is not cheap. It is very expensive and usually not applied. Gonococcal antigen in clinical specimens are determined by ELISA. It is easier than immunofluorescence test. And cultural method, it's very difficult to do cultural method because of fastidiosity of gonococcus, and it can be performed only in specific laboratory where specific artificial gonococcal media uh, presence, and the main case of cultivation, the main purpose of cultivation of gonorrhea is to establish antibiotic sensitivity, just for this purpose, but not for diagnosis, because it is more cheaper, easier, and quickly to do PCR, but not to do cultural method. You should know. Okay, this is about tests. So microscopic PCR and serological tests. Treatment and prophylaxis of gonorrhea. Because of rapidly growing resistance of gonococcus to antimicrobial agents, third-generation cephalosporins, for example, ceftriaxone and macrolides, azalides, azithromycin, are currently recommended for treatment of gonorrhea. For treatment of chronic gonorrhea, the injection of gonococcal killed vaccine can be administered to stimulate host immunity, because you know that gonococcus, they invade to the macrophage and cause incomplete phagocytosis, and to stimulate immune system, gonococcal killed vaccine can be administered. For protection of newborns against ophthalmia neonatarum, urgent eye installation of sulfacetamide, sulfacyl sodium solution, as well as application of tetracycline or azithromycin ophthalmic ointments are administered immediately after birth. And the last one is pathogenic urogenital chlamydia. Chlamydiosis is also very spread in the human population, and we have a lot of cases of chlamydial infection, and the main damage of chlamydial infection is a problem with urogenital system, and and as a complication is infertility, women and men's infertility because of chlamydia infection. Chlamydia are not usual bacteria. They have its specific peculiarities. They belong to order Chlamydialis, family Chlamydiaceae, and genus Chlamydia. And there are main pathogenic species is Chlamydia trachomatis, called trachoma. Trachoma, it's conjunctivitis. Lymphogranuloma venereum or Nicholas Fevre disease, inclusion conjunctivitis, and numerous non-gonococcal urogenital infections like urethritis and salpingitis, and chlamydia pneumonia cause human pneumonia, bronchitis, and sinusitis virus. And chlamydia psittaceae, it's a causative agent of avian disease ornithosis, psittacosis, that in common case may occur in several respiratory infection humans. Psittacosis or ornithosis is transmitted from birds. The source of infection, the source of ornithosis is bird, and it can be transmitted by contact or by direct contact or by airborne mechanism, and it manifests with respiratory tract infection. Usually, it was very similar to influenza by its symptoms. Morphology. So I said that chlamydia is not usual bacteria. They have its own peculiarities. Chlamydia as obligate intracellular parasites, so they can't multiply by itself. They need eukaryotic cell for reproduction. They are gram-negative, non-motile, non-sporoforming, very small size, and they have two stages in their life cycle. Elementary bodies elementary bodies, it's a free cell un, uncellular. It's a form which is outside of the cell. And reticulated bodies, it's a form of chlamydia which is, oh, sorry, elementary bodies, it's a outside and from the cell, and reticulate bodies, it's inside the cell. Elementary bodies measure 0.2, 0.3 micrometers, possess infection properties, being capable of invading the host cell. So the main purpose of elementary body to find the host cell and invade it. In the infected cell, elementary body is transformed into vegetative reticulating inclusion 0.8, 1.5 micrometers in size. They might be covered with capsule. After several reproduction, reticulate bodies convert again into elementary invasive form. The whole development cycle take about 48, 72 hours. So reticulate body, its main purpose is to reproduce itself. So look at this stage, look at this slide. So elementary body, its purpose is to find host cell and to invite it, to infect it. And inside the endosome, elementary body transform to reticulate body, and reticulate body start to reproduce itself. Multiplication, and this intracellular form is very is a mechanism of chronic infection, of persistation, because antibiotics and antibodies can't act on this form. They are not active on the intracellular form. and intracellular form is not sensitive to antibiotics and antibodies. This is very important information. And then reticulate body began to transform into elementary body, destroy the cell, and goes to find new cell, host cell. Here you can see electron photo, and you can see a cell with reticulary chlamydia, reticulary bodies of chlamydia, and you can see cell which was destroyed, and a lot of new infective form elemental bodies became free, and they start to find new cell to infect it. Chlamydia are primarily visualized by Romanovsky gene sustain, reticulate body, produce blue inclusion attached to cell nuclear membrane, while elementary bodies stay purple. Intracellular detection of bacteria is also performed by immunofluorescence technique. Cultivation as obligate intracellular parasites, chlamydia grown in cultures of variety of eukaryotic cell. They don't grow on nutrient media. They similar to viruses because they can't multiply, they can't reproduce without host cell. They need host cell for reproduction. That's why they can be grown on the artificial nutrient media. All types of chlamydia proliferate in embryonate eggs, particularly in the yolk sac. Various animal models are used also for cultivation, for example, mice. But cultural method is not applied for routine diagnosis because it is very hard, difficult, and expensive for routine diagnosis. Biochemical the properties they have weak biochemical activity, unable to synthesize ATP. That's why they need energy of the host cell. So so this uh, these peculiarities um, because they unable to synthesize by themselves ATP is the reason why there are obligate intracellular parasites because they need energy of host cell. Okay. Antigenic structure. Chlamydia possess group-specific antigens. These are hard stable lipopolysaccharides. Server-specific antigen are mainly outer membrane proteins, OMP. Virulence factor. Microbial LPS displays pro-inflammatory properties as endotoxin. The proteins of outer membrane, such as MOMP, are the bacterial adhesins. Together with cysteine-containing chlamydia proteins, they suppress phagocytosis, inhibit phagosome-lysosome fusion. Heat shock proteins and others stimulate cellular inflammation. Chlamydia possess type 3 secretion with activity of injectosome. The structure of T3CC are responsible for microbial invasiveness and intracellular persistence. So they use surface proteins to adherence, and also they use specific proteins for invasive invade to the host cell, and also they have LPS and shock protein. Resistance. They have low environment resistance. More stable are elementary bodies, which stay viable from 5-10 minutes within droplet aerosol phase. The temperature above 40 degrees and pH fluctuation rapidly inactivate bacteria, their survival might be longer at low temperatures and in clinical samples with high protein contents. Chlamydia are sensitive to all conventional antiseptics and disinfectants. Pathogenesis. Humans are the natural host of Chlamydia trachomatis, but you should know that Chlamydia psittaci they can be transmitted from the birds. The bacterium cases various human infection depending on the microbial server. Chlamydia trachomatis of 0D to K cause sexually transmitted diseases and may also produce the specific infection of the eyes, inclusion conjunctivitis, trachoma. The bacteria bind to the epithelial cell by multiply adhesins and to the infected cell by the action of type 3 secretion and impair normal cellular metabolism. Chlamydia persistence stimulate chronic inflammatory reaction within urogenital tract that may lead to the sclerosis. Propagation of chlamydia followed by the egress of elementary body by lysis or membrane body extraction result in degradation of urogenital epithelium. So, in the pathogenesis, important rule is the ability to invade play important roles in the pathogenesis. Chlamydia they adhere to the cell and then enter to the cell and start to multiply in the cell, and then they destroy. And that's why they can cause chronic infection. Usually, chlamydiosis, especially urogenital chlamydiosis, is a chronic infection because bacteria can survive inside the cell. They can persistent a lot of time in the human body. That's why after acute infection, chronic infection occur. And they destroy cell of urogenital tract because they reproduce itself in this inside the cell and because they have some proteins which cause inflammation. Laboratory diagnosis of chlamydial urogenital infection, specimen from urogenital tract or conjunctiva can be obtained, and the presence of chlamydia inclusion in smear is determined by microscopy with Romanovsky James sustain and Michelson microscopy, but nowadays we don't use this method very usually. The swab specimen should be placed into chlamydia transpiration medium and kept at refrigerator temperature before transpiration to the laboratory. Cultural tests are very difficult, that's why they are not applied. The laboratory diagnosis of chlamydial infection in clinical practice is mainly based on PCR. It is more sensitive than culture and other non-application tests. Serological diagnosis of chlamydial infection by ELISA indicated the growth of serum antibodies against the pathogen. The rise of levels of specific antibody occurs during and after the acute chlamydial infection. Okay. And treatment. Macrolides and azolides are commonly used for treatment of urogenital chlamydial infection. Erythromycin is given to pregnant women. Tetracycline can be administered as well. Aminoglycoside and beta-lactams are clinically inefficient due to the poor availability to chlamydia inside the cell. Topical tetracycline or macrolides are administered in case of inclusion conjunctivitis, sometimes in combination with systemic drug. Efficient vaccines from prevention of chlamydia infection are not yet elaborated. Thank you for attention. If you have any question, please ask me on my in WhatsApp or in my email.